Hello and welcome to this webinar organized by Radcliffe Medical Education and the International Society of Cardiovascular Pharmacotherapy. I'm Juan Carlos Kasky, Professor of Cardiovascular Science at St. George's University of London in the UK, past President of the ISCP and Chairman of the Crowdsourcing project that we will discuss today, and which was carried out to understand current practice amongst the cardiology community worldwide regarding antiplatelet treatment in non-ST elevation acute coronary syndrome patients at high bleeding risk. I'm delighted to be joined today by three members of the excellent International Steering Committee that led this project and who will be discussing different aspects of the study. Professor Deepak Bhatt, who is the Executive Director of Interventional Cardiovascular Programs at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School and co-chair of this project. Professor Felicita Andreotti, who is a Professor and Medical Director at the Gemelli Hospital and Catholic University in Rome, where she coordinates cardiovascular research within the Scientific Directorate. And Professor Dominic Angelijo, who is Professor of Medicine, Director of Cardiovascular Research, and Director of the Interventional Cardiology Fellowship Program at the University of Florida College of Medicine. The crowdsourcing project that we'll be talking about today resulted from a collaborative effort by the International Society of Cardiovascular Pharmacotherapy, the ISCP, and Radcliffe Medical Education, who joined forces to develop a study to assess current clinical practices in different world regions regarding the treatment of non-ST elevation acute coronary syndrome patients who are at high bleeding risk post-PCI. This activity was supported by an unrestricted educational grant from AstraZeneca and coordinated by an international steering committee that Deepak and I had the honor to co-chair. The findings of the study were recently published in the International Journal of Cardiology. And what we would like to do today is to provide the rationale as to why we carried out this research, discuss the unmet needs in this particular patient population, and mention the most important findings of the study and its potential clinical implications. I would like to start by asking Dr. Deepak Bhatt if he could briefly explain what the project involved and give some context as to why and how it was carried out, basically the rationale for this crowdsourcing project. Deepak.
Great. Well, thank you very much. I should really first start off by thanking you, Professor Kasky, for inviting me to co-chair this program with you. This was really your brainchild, along with the efforts of Radcliffe Medical to bring this project to fruition, to really get it off the ground in the first place. And I'm grateful to you for bringing me on board. It's been a remarkable experience assembling a steering committee of international experts and then collectively writing a paper. But by collectively, I don't mean a paper just amongst ourselves and the Radcliffe medical folks. Certainly all of us worked on the paper, but it was a much larger group that contributed. The whole idea behind this international crowdsourcing, where we had a survey where we got input from people from all around the world, and those people are acknowledged in the supplement to the paper. As you just mentioned, the paper was published in the International Journal of Cardiology relatively recently, but in the online supplement as well is a list of all the different collaborators, essentially people that contributed to this crowdsourcing survey. So before getting into the specifics of what it was about, just the process itself, I found really quite fascinating and futuristic. That is, I could see in the future gathering data in this way in terms of how are physicians practicing, not just in a particular region, but around the world. Of course, there's all sorts of august writing committees that put together guidelines. That's nice, but sometimes there's a disconnect between what the guidelines say, what the evidence actually supports, and what people are doing. And potentially this approach that we were pioneering in this paper that is using a crowdsourcing approach to get a sense of what physicians were doing in real life can help inform future guidelines. I think there's probably a long way to go with that sort of approach, but we've taken the first steps in at least figuring out what are doctors out there doing. Now, the specific topic that we addressed had to do with the treatment of non-ST segment elevation acute coronary syndromes, and specifically even that in patients at high bleeding risk undergoing percutaneous coronary intervention. So it was a very focused question that we were asking. Perhaps that in part had to do with who the commercial funder of this educational activity was, AstraZeneca, and their interest in antiplatelet therapy patterns. And I think it's an interesting question, one that the steering committee members were independently of the funding source interested in and have published on and spoken about. But again, putting aside the specific question for just a moment, I think this approach of using a crowdsourcing survey, using social media, Twitter, other sort of modern techniques to get a sense of what's actually going on in real life can be very informative in terms of planning clinical trials, seeing what the baseline practice patterns are, in terms of writing guidelines and seeing how far afield are the guidelines from what people are actually doing. Does it make sense to issue guidelines when there's a total disconnect between what the guidelines say and what might be going on in the field? So I think there's a lot of potential for the approach that we studied in the future. Now, there's got to be some tweaking, I think, of what we did in terms of response rates and representativeness of different geographic regions. I think there are things that perhaps in the future we could do better, but still, as a first step, I think this paper, this approach in the field of cardiovascular medicine, or more broadly in the field of medicine, is something special in terms of what it might have started. So now let me just say a couple of things about specifically what the goals of this project were beyond the methodology, which, as I just summarized, I found truly transformative and revolutionary. And the topic was looking at non-ST segment elevation ACS patients and how those that have high bleeding risk undergoing PCI are treated, to get a sense from around the world, from physicians around the world, what are they doing with antiplatelet therapy? Have they reacted to any of the data, such as from the Twilight trial, that support de-escalation strategies of antiplatelet therapy, in that particular case going from aspirin and ticagrelor to ticagrelor monotherapy versus dual antiplatelet therapy, and other studies that have in general supported that de-escalation strategy, at least in the specific trial populations in which those studies were done. Now, we were looking specifically at patients at high bleeding risk and how they're treated. The trial I mentioned, Twilight and others, didn't necessarily focus on high bleeding risk per se, but our interest was in examining those type of patients, those at high bleeding risk. So we were extrapolating as a steering committee from what the data showed to apply it to patients at high bleeding risk, post-PCI, post-ACS. We had our own thoughts, not necessarily all in agreement in terms of what the quote unquote right approach might be. But the goal here wasn't necessarily to say right or wrong, but rather to see what is going on around the world among physicians. How are they reacting to the new data about dual antiplatelet therapy, intensity of dual antiplatelet therapy, duration of dual antiplatelet therapy? How are they reacting to guidelines, some of which are already out of date and don't reflect the newest therapy? How is it that they are incorporating in their own practices all these different sources of information, evolving clinical trials, CME programs, other sorts of symposia, product labeling? There's so many different inputs that could go into a physician's decision-making, but we just wanted to get a sense of what are they actually doing. So that was the overarching goal of this project, both testing a new methodology of getting information, but then summarizing it in a way that is hopefully useful, as I mentioned, for a variety of future purposes.
Thank you very much, Deepak. May I briefly ask you, what do you reckon was the most challenging, or one of the most challenging elements in defining the crowd and in identifying the correct numbers?
Yeah, so this is a great question. So surveys are always a bit tricky because it all depends on the response rate. That is, if you survey 1 million people and 10 people reply, well, then that's likely not a representative sample. So a goal of survey-based research is always to try to get a representative sample. And that can be more challenging if one doesn't actually know the denominator and is just, getting a bunch of responses back and making sort of conclusions, generalizing it to a population based on whoever happened to respond. So there can be some self-selection bias in terms of people that respond. So if we were doing a survey, for example, about how happy are physicians, chances are the ones that are super happy are probably not going to be filling it out. The ones that are unhappy might be more likely to fill it out. The ones that are, just ready to throw it all in probably don't have the energy to fill it out. So there can be biases going in a number of ways in terms of who actually responds to surveys and the answers that come in. So, no survey methodology is perfect, but, we were lucky in that we got responses from several hundred professionals. We were lucky that it was about 70 countries or so. So I think, for a global sort of enterprise with a, modest budget that we were working with, it was a pretty good response rate and a fairly representative group of people, again, numbering in the hundreds, not in the thousands. And, representation from every region of the world wasn't necessarily terrific. In some cases, just a few people from a particular country. So probably not fair to then generalize and say, 5 people responding from a country represents what that country is thinking or doing in terms of its medical practices, in this case, with respect to antiplatelet therapy. So, I think there's some challenges in terms of interpreting the data. That's why I think more than anything, to me, it's just a great methodology, but the start of a great methodology of how one can collect data about clinical practice patterns. This sort of thing comes up all the time where, if we're in guideline writing committees, we want to get a sense at least of what are people actually doing now, rightly or wrongly in our opinion, but what are they actually doing right now? Same thing in planning trials, say, using this as a specific example, planning a trial of, say, a novel antithrombotic. It'd be great to know what are people actually doing right now in practice. That allows one, to plan a trial or see if a trial is even feasible at the current time. So for trial planning purposes, it can be useful just for a variety of different reasons. So, I think it is really a very great contribution that we've made to the literature, not necessarily specifically about antiplatelet therapy. That as well, it's I think a modest contribution in that regard, but the methodology itself does show, with a relatively modest budget, what we could do in terms of gathering data. But if we were going to repeat the experiment, I think it would have been nice to get responses from thousands of people instead of hundreds of people. But once we're talking about that scale, that doesn't, it's not necessarily such a cheap thing to do. As well, I had thought using things like social media would lead, to just an incredibly high response rate and also larger numbers of people. But I think it really discovers or helped us discover the reality that lots of physicians aren't on social media. And I'm not saying that that's good or bad that they are or aren't on social media. It's just I'm describing the reality. And I think that means even with all the changes that are occurring in the world with social media and how people are connected, to an extent, physicians have been somewhat isolated from those changes. And a lot of how we learn and communicate in medicine is still based on more traditional ways. Again, I'm not saying that's good or bad. Social media certainly has its pitfalls, but it does underscore, I think, the potential, perhaps, for us to use various more modern approaches to communication, such as social media, in a way that enhance medical communication and our global education on different matters. I mean, in this case, it was a specific question having to do with antiplatelet therapy and high bleeding risk patients. But again, I think in the future, we can do a lot more with this type of methodology. Even with the question asked, I think we gained a lot of insights. I think one thing that we learned, this is probably not surprising, but there was a lot of variability in practice. I don't know that there was necessarily a consensus, other than things that were, really obvious. I mean, if someone's actively bleeding, nobody's going to, give them intense antiplatelet therapy. But putting aside extreme sort of scenarios for the more common questions that were actually asked and scenarios there, there was a lot of variability in practice. And I think that just goes to show it's tough to know what to do when there's so many inputs that a physician receives from guidelines that are sometimes out of date, from new data, but new data where the interpretation isn't always agreed upon. I mean, within our steering committee, we didn't really reach a consensus in terms of what the optimal approach to antiplatelet therapy is, even when we narrowly defined it as patients with high bleeding risk post-PCI. There was still a lot of variability in response in the responses that the steering committee gave, let alone the responses from the larger 500 plus people that actually responded from around the world. So again, I think the first step in any sort of exercise is just to gather data. And that's what we've done here quite successfully. Now the question that comes, if we're taking this any further, is are we going to do anything on the data? Is there anything that are actionable in a way that most people would agree with? And I think to do that, there sort of has to be a consensus in terms of what the quote unquote optimal or right way to treat a particular patient is. And perhaps an area that's especially challenging is high bleeding risk patients, because there's going to be a lot of strong opinions, but not a ton of data, because most trials of antiplatelet therapy have excluded patients at really high bleeding risk. And then we're left extrapolating from other data sets, applying it to patients with high bleeding risk.
Yeah. Thank you very much for this, Deepak. Thank you very much indeed. Yes, uncharted territory, but promising methodology. And just a question for Professor Andreotti. What were, in your view, the most relevant findings in this study, and how did the crowd respond, in your view?
Thank you, Juan Carlos. Thank you, and also Dr. Vatt, for having me on board of this innovative project, indeed. The crowd, as Dr. Vatt said, involved several hundred, 559 responders. About 50% were interventionalist cardiologists. About 50% had more than 10 years of experience, and about over half were from teaching hospitals. And the project aimed to pose 4 basic questions, I would say, quite fundamental. The first, and the response to the first question was, in these high bleeding risk, non-ST elevation, acute coronary syndrome, post-PCI patients, would the crowd consider monotherapy within 12 months after initial DAT? After initial dual antiplatelet therapy? And here there was a very, very homogeneous response. 94% replied yes, they would indeed consider monotherapy within 12 months of PCI in this high bleeding risk non-ST elevation ACS population. And I believe this is indeed in line with the European Society of Cardiology guidelines that offers, although with not the strongest class of recommendation, a shortened DAT duration of up to 3 months or 3 to 6 months in these patients. So here we had very homogeneous response. In contrast, interestingly, to the subsequent questions, we had a sort of dichotomy. Our second basic question was, which agent would you actually be selecting for the monotherapy within 12 months of PCI in this high risk, high bleeding risk population? And in my mind, very interestingly, there was roughly an equipoise, a 50-50 distribution in the responses for monotherapy with either aspirin or with a P2Y12 inhibitor, either clopidogrel or ticagrelor. Again, I think this reflects actually quite closely the lack of a single strong class 1 recommendation from available guidelines, and reflects additionally the fact that the European guidelines, for instance, issue 2 equally strong class of recommendation 2A for either aspirin discontinuation or P2Y12 inhibitor discontinuation after initial dual antiplatelet therapy. Then there was a third basic question, and that was, for how long would you be doing a dual antiplatelet therapy treatment in this high bleeding risk non-ST elevation ACS population undergoing PCI? Again, and I think this is really shows the amazing power of numbers and statistics, the results were almost exactly in equipoise, with roughly half selecting up to 3 months of dual antiplatelet therapy and the other half up to 6 months or longer. And in my mind, this is not a chance finding. So with the limitations of this tool, I think the responses actually give us quite a confident the plausible answer to these fundamental questions. I don't think it's a chance finding, but rather a close reflection of the currently available European guidelines that, as I said, are not top strength and are open to both options, either up to 3 months on the basis of global leaders and Twilight, or up to 6 months or longer based on a number of meta-analyses that have shown enhanced protection from ischemia, but also enhanced bleeding with prolonged dual antiplatelet therapy. Then there was a final, very important question that the project posed to the crowd, and that is, how do you go about defining high bleeding risk? As we know, there are a number of scores. Some are quantitative, such as the precise DAPT or the DAPT scores. Others are qualitative, like the Academic Research Consortium high bleeding risk definition. But the surprising thing here, I think, was that the single most frequently used tool chosen by the crowd to define high bleeding risk was clinical judgment. So I think, again, this is telling us something, that it's highlighting the lack of a homogeneous guidance on the use of alternative tools. So in conclusion, the crowd was almost unanimous in choosing monotherapy within 12 months of PCI in high bleeding risk ACS patients. In contrast, the choice of the antiplatelet agent, the duration of initial DAPT, and the tool to assess high bleeding risk, I believe, reflect important areas of unmet need.
Thank you very much, Felicita. And you, thank you for summarizing this so nicely. And highlighting the key questions that we were trying to answer. May I ask you, it's interesting that the study showed that most people really follow guidelines, but still a large proportion will move aside from the guidelines if there is no clear-cut recommendation and use clinical judgment. Do you think that this kind of approach would actually help in the generation of clinical recommendations, not just clinical studies or design of studies, as Professor Butt was referring to, but guidelines? Would this in a way help resolving the conundrum of different regions in the world not being able to implement every single recommendation of these international guidelines? Would the crowdsourcing element be of any help?
Yes, thank you for this question. It's quite a difficult point. We know that there's nothing more rigorous than a well-designed trial to test hypotheses on treatment selection. I think the tool is very good to give us an idea of what is currently being done, of highlighting areas of unmet need, and only where a trial is at the moment not available or perhaps practically not feasible, I think we should use this tool to actually provide answers to treatment choices. I think this tool is really telling us where future research should be directed. I think it's a good tool to tell us where we are in terms of clinical questions, in terms of unmet need. I think the power of this tool is to highlight this, and this specific project has done that, in my mind, very clearly on those 3 points: which agent, for how long, and how to assess bleeding risk. To actually respond to this unmet needs, I think we probably need different sort of tools.
Right. Thank you very much for this. And on this note, I think the question to Professor Angelijo is very much linked to what we've been discussing. Dominic, what do you think are the potential implications of the findings of the study? Perhaps expanding on what Felicita has highlighted. And again, although we already heard Deepak and Felicita telling us about how they feel about the usefulness of the crowdsourcing methodology, what is your own view on this? So 2 questions is potential implications of the findings in the first instance, and then your own view on the usefulness or potential usefulness of the methodology.
Sure. So again, thanks for having me, Juan Carlos, and thank you also, Deepak, for your leadership on this project. I would like to use the term awareness because I think these type of approaches of understanding what the crowd is doing, first of all, allows us really to understand where do practicing clinicians stand with regards to certain therapeutic areas. And we touched upon a very, very important topic, which is non-STEMI patients with high bleeding risk. Now, although this is a concept that has been around for a number of years, maybe not all physicians in practice may consider this in their daily clinical decision making. But so it was very, very nice to see that there was a lot of consensus. Actually, one of the few areas that Felicia just mentioned too about awareness of the topic and how we need to adapt to this. And I say this as something that is important because if we would have not found that result, then we would be having a different conversation right now. And maybe there was more of an educational need as a result of this crowdsourcing. So this leads us now to the next part, which is now there's awareness of different practice patterns. And I'm fully in line with what was just mentioned about how this can be informative for potentially informative for practice guidelines and also for clinical trials. And I'll expand a little bit upon that because this has clinical implications. We know that when guidelines are developed, they're typically developed based on evidence, based on randomized clinical trials or sound registries. But always when guidelines are released, there are certain reactions, right? Reactions from the crowd, the people that we've sourced as in this survey. So I think having this information could, I believe, help guideline committees in the way they phrase or structure certain recommendations. So I would not saying this specific crowdsourcing, but I think there is a potential. And the same way there is a potential with helping in design of clinical trials. Yes, clinical trials sometimes do test drugs, but sometimes they also test strategies. And this is exactly what we were looking here in this survey. We're looking at strategies, what is out there. Nevertheless, I do believe that there's still room for improvement. We all would have liked to have seen a response rate of several thousands. We were in the upper 500, which was good, but definitely not large enough to make any firm recommendations of any sort. So what are the lessons that we've learned? How can we improve? Well, first of all, I think social media is a very, very strong tool to achieve this. We all know that at the beginning, maybe there could have been, so there were some technical issues, which later on during the crowdsourcing were improved and allowed to enhance the response rate. I do believe that if moving forward, we should try to keep the responses or the duration of the survey a little bit shorter. We all receive surveys in our inbox and our email, and the first thing we see when it's 10 to 15 minutes to complete, we're saying, I'm passing. Maybe we need to be a little bit more focused and more accessible. But definitely a great starting point, a lot of potential. On one hand, it could be a sort of a quality assessment and room for quality improvement if there is an awareness. And at the same time, it could be a foundation for guidance, not only for guidelines, but also for future trials.
Thank you very much, Dominique. Something which I think was obvious to all of us when we started this study was that it was really uncharted territory. And there were so many things that we needed to define and try to anticipate that made it quite difficult. But soon it also became clear that we were getting very interesting information in relation to regional needs, and some people actually highlighting differences in social organization, organization of the medical service in each of the countries, access to public health areas, which were not identical in each region of the world. So, do you think that that's a question for everyone? Do you think that perhaps what we have learned from this study in relation to the important information that comes from a crowd could be used to inform design of studies, future studies, and also design? I mean, I'm not saying empowering the crowd to do the guideline, but actually getting the crowd information for those who are thinking about the guideline, taking into consideration things that otherwise they may not even think they exist.
Oh, I'll start off since I just left that part. I mean, the answer is absolutely yes, absolutely yes, and there are obviously differences in practice patterns across the globe, also based on the resources that are available, and these resources may have an impact on the drugs that are being used and the strategies implemented in this specific case for the treatment of patients with non-STEMI. And even within certain countries, for example, the United States is a very, very large country, and there are differences in practice patterns between rural areas, for example, in the Midwest versus more metropolitan areas. So the short answer is absolutely yes, but we need larger numbers.
Yeah. Deepak, what you think about this sort of possibility of using this information in this way?
I think it's a great idea. I agree with everything Dominic just said. And you know, that you said before, that is, we wouldn't necessarily write guidelines on a crowdsourcing format, though maybe we could or should. I mean, even, you know, nothing is an impossibility. I mean, there are other, you know, things that humans are doing on the planet that really are based on crowdsourcing. You know, maybe the guidelines wouldn't be any worse off if they were done with the wisdom of crowds. I'm not sure. I think it sort of depends on exactly who is in that crowd. That is, I think if we just open it up to everybody on Twitter to opine, you know, then we would get some of the foolishness that we're getting about the anti-vaccination stuff and other, you know, people that aren't even physicians, or some, sadly, who are physicians but are on the fringe. But if we, you know, restricted it to people who are actually in the practice, say, of cardiology, opining about cardiology guidelines, there might be some wisdom there that we're not getting. You know, maybe part of the reason guidelines aren't adopted more broadly is because, not of lack of awareness, but because the physicians have thought about them and just disagree with them. And at a minimum, it provides an opportunity for education if the guidelines are correct. And perhaps it provides an opportunity to improve the guidelines if they're in fact wrong, or if they're just not applicable globally. That is, it may not be reasonable to say, you know, give everybody a PCSK9 inhibitor and mechanical support after a STEMI if they're in a region of the world where neither of those things can be afforded, you know. So it might really provide a lot of insights, getting this sort of information, you know, whether it's actionable for the purposes of guidelines or other things. You know, I think we have to wait and see. I think as well, there would have to be a very large number of people responding and a representative, you know, a sort of number of people responding. We'd have to see, you know, what's the incentive to make people respond. Otherwise, you know, potentially we just get a sample that's not representative of anything. But nonetheless, the bottom line is I think there's a lot of potential value in what we've done. And I think we and other groups, you know, should continue to experiment with this type of crowdsourcing effort to see, is there something, you know, that we're able to do that really moves the field forward. I mean, it could be a way even of just finding out, you know, what do physicians think are important research questions? You know, maybe the questions who are answering in trials aren't the ones that are the most pressing ones in the minds of physicians or the patients they represent. Now, obviously, when it's industry-sponsored research, there's always, some drug or device-based, goal there to test something. I personally don't think that tarnishes the research in any way, because usually those trials are well-funded and well-powered. I actually think industry's been a great partner for drug and device-based research, but it does sometimes limit the questions that are asked. That is, it does tend to limit questions about strategy or combinations of different therapies, or what order should different therapies be added? When should therapies be subtracted? Those are questions that are rarely asked, by industry-funded trials, but, perhaps those are questions that are very important, and crowdsourcing could help us determine which questions are really important. Getting those questions then funded could be a separate challenge.
Yes.
Maybe one that is also not so easy to surmount, but there are other fields of human endeavor where crowdsourcing is used to raise funds to do things. So if people think it's really important to do something, well, then maybe they need to speak with their wallet and help fund it in some small way.
Excellent. Felicita, what's your position on this?
Yes, I enjoyed the discussion. And in fact, we haven't mentioned, for instance, the level of evidence that goes with the strength of recommendations of guideline documents. And as we know, there's level A, level B, and level C. C is expert opinion. So what crossed my mind is perhaps in a blinded way, comparing the expert opinion of the guideline writers compared to the expert opinion of expert crowd. So well-selected crowd might be a very interesting exercise.
Very interesting point, indeed. Absolutely, absolutely. So I'm afraid that this is all we have time for today. We hope that the audience has found this session both informative and engaging. And I'd like to thank Radcliffe Cardiology for organizing this crowdsourcing project, the ISCP for their endorsement and advisory committee work, and AstraZeneca for providing an unrestricted educational grant. A reminder that this event can be viewed on demand at www.radcliffecardiology.com. I would like to also, of course, thank our fantastic faculty today. Deepak.
Yes, thank you very much. Great being with you.
Dominic.
Thanks again, Juan Carlos. This was great.
And Felicita. Thank you very much. See you soon.
Goodbye.
Bye-bye.
Bye.